the other thing I would mention is this was one of the first, I think, for many years of a placebo-controlled study, double-blind, right? And you mentioned most of the other studies compared to sorafenib, they were open label, and obviously that introduces different concepts in how an investigator manages patients. But you know, in frontline, currently approved, we have single agent len, single agent sorafenib, and then when we think about IO, we have atezo-bev, IO, and pure VEGF. We have durvalumab and tremelimumab, CTLA-4 and PD-1, PD-L1 inhibition. And we have a signal from LEAP-002. We saw data that was published this year with another TKI, rivasirnib, and IO, and pembrolizumab, which is positive, not globally approved. How do you think scientifically about IO and VEGF versus IO and IO and IO and TKI? Because, you know, this is an active regimen we saw from LEAP-002. And I don't think the patients responding to TKI and IO are necessarily the same as IO-IO and IO-VEGF. What's your thoughts on that?
Well, so this is a complicated question, but I would say that those regimes that incorporate beva, meaning IMbrave 050, IMbrave 150, and now this regime in intermediate that we know, Emerald 1, right? That also incorporates beva. All these trials have been positive combined with IOs. So something is happening certainly with a synergistic effect or an additive effect, and you will learn about that. We have just submitted a paper in Cancer Discovery, mining all the data with single cell sequencing and all the stuff. So probably bevacizumab has two functions. One is an immunomodulator that helps the effect of the checkpoint inhibitor on one hand, and second, it has anti-tumoral activity per se. And this happens very early on in the curves. If you see all the curves, it hits very early on, and they stop the trial very early. This is on one extreme. On the other extreme, we have durvalumab. Durvalumab, the curves are identical the first year and then start separating because those patients that achieve objective response with durvalumab are long-lasting responders, and they reported 4-year survival for this arm of 25%, as opposed to sorafenib 15%. That's a 10% difference. That's why they have the ESMO 5 score, right? And in between, we have the TKIs. I think that the TKIs are active and enhance the activity of IOs, but we have not been able to capture that, at least with lenvatinib, but I think that this combination is happening. What is counterintuitive, is if you can recall, was what happened with cabozantinib. Cabozantinib was strange. I mean, the objective response went down instead of going up. So something mechanistically happens there that we don't understand. So I would say that there are 3 types of mechanisms. The impact of IO is at the very end, only with the responders, and it's a smaller population. Whereas when you incorporate beva, the population, the benefit is wider, both in objective response and disease control rate, which is important as well. And in between, we have the TKIs, IOs that at this point, I mean, we have only these guys the paper in Lancet, that is carbolizumab plus an apatinib analog, right? Ribociclib.
So very important thoughts and concepts. And in closing, you mentioned the Emerald 1 study, which there was a press release about meeting its positive endpoint for progression-free survival of durvalumab and bevacizumab in patients who are getting a TACE, and TACE is the control arm. With that being said, as it regards to lenvatinib and pembrolizumab, we still have the LEAP-002 study, right? And a somewhat similar design, which is for intermediate patients, TACE plus lenvatinib and pembrolizumab versus TACE alone or TACE with placebo. What do you think about that in the context of LEAP-002, the data we just discussed, positive data with Emerald? Does this combination, is it still alive, so to speak?
So I would say that, I mean, the MLL1, there is only a press release. Again, BEVA is in the picture. And the primary endpoint is progression-free survival. So we define somehow how important maybe progression-free survival, if it is very strong, as a surrogate of survival, has a ratio less than 0.6. But in intermediate, we don't know what's the, because it has not been reported so much, right? So the question here is which, because this is the only primary endpoint, single progression-free survival. The same goes for LEAP-012, single endpoint, and I think that the combination has a chance because of the results of LEAP-002, and because in the control arm you have TACE and you don't have lenvatinib. The downside is that the sample size is quite small, so the delta that has a ratio and the magnitude of benefit should be substantial to capture the benefit. But I think it has a chance.